My lady, good morning. Can I check that you can see and hear me?
I can, thank you, Ms Blackwell.
Thanks.
Good morning.
And we can see and hear you too. Good morning. May I begin this week by calling Dr. Claire Wenham, please?
Let's just stand and repeat after me, please. I do solemnly, sincerely and truly
I do solemnly, sincerely and truly
declare and affirm
that
the evidence I shall give
the evidence I shall give
shall be the truth,
shall be the truth,
the whole truth,
the whole truth,
and nothing but the truth.
and nothing but the truth.
Will you give your full name, please?
Yes, it's Claire Wenham.
Thank you very much. Dr. Wenham, you should have in front of you a copy of your report on unequal gender impacts of the pandemic, which bears our reference number INQ 000657974. Please can you confirm that that is the expert report that you've provided for the purposes of this module?
Yes, it is.
And that the facts stated within the report are true to the best of your knowledge and belief?
Yes.
And that any opinions that you have stated in the report represent your true and complete professional opinions?
Yes.
Thank you. Welcome back to the inquiry. I know that you were last here during the public hearings for Module 2, is that right?
Yeah.
I will introduce you again, if I may. You are an academic expert in global health security, global health governance and global health policy, and you hold the position of Associate Professor of Global Health Policy at the London School of Economics.
Yeah.
You have a PhD in International Relations. And during the COVID-19 pandemic, you co-founded the Gender and COVID-19 Research Group, bringing together academics from 11 countries to conduct real-time gender analysis to identify and analyse the gendered dynamics of the response. And you have advised the European Union, World Health Organisations, United Nations Women, the European Parliament, World Organization for Animal Health and the German government on policy related to gender and epidemics and pandemics.
That's correct.
Thank you very much. In Module 2, you gave evidence on gender inequality and discrimination, which you said was pervasive across UK society prior to the onset of the pandemic. And you said that government policy always has a role to play in ameliorating patriarchal social norms that serve to subjugate women. And without conscious efforts and resources, the unequal position of women will be exacerbated.
Yes.
In Module 10, you have prepared and are giving evidence today about a report which really sets up and takes off where you left off in Module 2, because it deals with how the COVID-19 pandemic exposed and intensified existing gender inequalities across the United Kingdom, with women disproportionately affected in multiple and intersecting ways. And what you tell us at paragraph 2 of your report is that from increased unpaid care responsibilities and heightened risk of job loss in female-dominated sectors, to disruptions in access to healthcare and rising rates of mental distress, the crisis magnified structural disparities across our society, and that these impacts were particularly severe for women already facing disadvantages, such as single mothers, disabled women, ethnic minority women, migrant women, and those in precarious work, which deepened socio-economic inequalities. Your evidence today predominantly then examines the unequal effects of the pandemic on women in the UK, highlighting how public health measures, economic shocks and service disruptions contributed to widening gender gaps. And you have also set out to show in your report any unequal effects on men in the UK, where it's possible for you to have done so within the area of your expertise. Can we start then, please, with a discussion of rates of infection, morbidity and mortality, which you start to tell us about at paragraph 3 in your report. You say there were notable gender differences in infection rates of COVID-19 in the UK, influenced by biological, social and behavioural factors. Explain to us, please, Dr. Wenham, what those differences were.
Well, so for example, we know that overall infection rates were pretty much comparable between men and women across the UK if you look at the whole pandemic as a whole.
Yes.
But we know at different stages in the pandemic, different people were more likely to be infected than others. So, for example, earlier on in the pandemic, it was more likely that women were infected. Now, this partly was a testing bias because if you remember early on in the pandemic, it was only certain populations who were able to get tested, including healthcare workers. So you see this disproportional increase. But then we see that then these infection rates are also predicted by sectors of the economy people are working in. So we see differences of infection between people who are working in frontline sectors, healthcare workers, people working in schools, people working in retail, people where you're coming into contact with people much more, are more likely to be women, and therefore we see increased positivity amongst those people. Now, that is then different to rates of mortality. And again, it's now undisputed that, men were more likely to die in the pandemic. And again, different sectors of male labour forces were more likely to die than women's, for example. But it's important to note that there are these differences in both infection rates, positivity and mortality between men and women, both based on where people are working, where they are on a day-to-day basis, how they're getting infected. There are biological differences that we are learning more and more about, and I am not a clinician, so I defer to clinicians to explain this, but, different responses to how male and female bodies respond to viruses. But we also know, and there's decades of research, that health-seeking behaviours are different between men and women, right?
Right.
So you're more likely to maybe test if you're a woman. Therefore, it might be that there are higher positive infection rates amongst women because women are more likely to go and get tested in the first place than men. We also know the converse being that men are more likely to delay health-seeking behaviour. So it might be that men had poorer outcomes because they delayed treatment for longer, for example, because that is a recognised trend in how men and women interact with health services.
Thank you. So lots of different factors to consider, including one that you've just mentioned, occupational risk. Yeah. So it made a difference depending on the type of work that people were doing. And as you've said, the exposure that brought them to risk of contacting the pandemic.
Absolutely. If you're working in a sector of the economy which can be done at home and you can stay at home, you're less likely to be infected with the disease. If you're working in a hospital or in an education setting, you are more likely to come into contact with multiple people in the course of a day.
Yes.
And in the UK, people who work in the healthcare sector, in the education sector, are more likely to be women than men.
Right. But you tell us at paragraph 7 that male healthcare workers experienced a statistically higher COVID-19 mortality rate compared to the general population and to their female counterparts, while the risk of death for female healthcare workers was comparable to that of the general population. Yeah. What might be the reason for that? I think it's we don't necessarily know for certain, or I certainly can't tell you today what that is. It's probably multiple factors around, intersecting factors of who those male healthcare workers were. Yes. There are multiple other intersecting factors. All right, thank you very much. Were pregnant women at greater risk than non-pregnant women?
Yes, we know that there were poorer outcomes for pregnant women infected with COVID, particularly those in their third trimester of pregnancy. We saw these risk factors both in terms of maternal mortality and an increased rate of maternal mortality for women who were infected with COVID. But this also manifested in preterm labour and stillbirth increases. And again, I think it's important to note that this wasn't uniformly across pregnant women across the UK. The impacts disproportionately fell on Black, Asian and minority ethnic women, pregnant women in the UK.
Thank you. Well, you deal with this at paragraph 9 of your report, and you say that those with underlying health conditions, those who were clinically vulnerable or overweight or over the age of 35 and from a minority ethnic group were particularly at risk. And you give some statistics from Oxford University. You say that significant ethnic disparities were shown. 55% of pregnant women admitted to hospital with COVID-19 were from Black, Asian and minority ethnic backgrounds, despite those groups accounting for only 25% of births in England and Wales. And that Asian women were 4 times and Black women 8 times more likely than white women to be hospitalised with COVID-19 during pregnancy. What did your research find in terms of disparities, geographical disparities across the United Kingdom?
So we don't necessarily have broken down data on geographical disparities, but I think it's important to highlight here that these impacts on pregnant women across racial lines in the UK do mirror broader risks of maternal mortality and poorer health outcomes for women across the UK in routine pregnancies outside of COVID. I mean, in the UK, yes, you're much more likely to die if you are a Black woman who is pregnant than a white woman who's pregnant. And I think, this mirrors broader structural inequalities in our healthcare system for pregnant women in the UK.
Thank you. You then go on to discuss in your report the risk of death for disabled females at paragraph 10. Did you find that the more severely disabled the female was, the higher the risk of death?
Yes.
Right. And did you also find that women were 20% more likely to report long COVID than men?
Yes, absolutely.
Were you able to assist in terms of any reason for that?
Well, again, I think it's multifaceted. I don't think there's one simple answer. I think, for example, women are more likely to report healthcare symptoms, so it might be a reporting tension.
Yes.
Women are also more likely to be undertaking unpaid care within homes or in communities, and therefore they might be less able to recover as much as men if they are also, looking after children, looking after their neighbours, looking after elderly relatives, and therefore that might impact recovery times. There's also increasing evidence coming out now showing the relationship between those who, or the greatest risk of people experiencing long COVID being of menopausal age women, and the similarities in symptoms reporting between long COVID and menopause. And actually it might be a tension around how these issues are being reported and a confusion around providers or healthcare providers' understanding of both those issues in and of themselves. But there's definitely an interrelationship between those two areas.
Thank you. And you conclude this section of your evidence by telling us at paragraph 13 of your report what the main lessons for us to take from your research and findings are. And please could we display INQ 000657974, which is your statement, Dr. Wenham, and have a look at what you say the main lessons are in this area. You say, first of all, that there may be gendered differences in infection with future pathogens, that these may be caused by biological reasons or social differences in society or employment, or engendered differences in behaviour. That recognising these patterns early can then lead to enhanced and targeted public health interventions to protect those at greatest risk. That enhanced public health messaging and communication in accessible formats are needed to target those who are less likely to believe they are at risk or be less able to protect themselves from that risk. For example, those from lower socioeconomic groups and those more likely to be receiving health or social care. Just pausing there, does that also include a need to ensure that messaging and communication is translated into different languages to touch those women in society who are not able to understand them in the English language?
Absolutely. We know that women are not a homogenous group. The women who are most at risk from all the issues I detail in this report are those who have multiple intersecting characteristics, including language barriers. So, being able to reach the most vulnerable, the least able to protect themselves from whatever area we're talking about is paramount to enhance women's experience of future pandemics.
Thank you. And finally, in your list, to ensure that PPE is available for all those in frontline health and social care roles or those in a range of settings who require PPE and an appropriate sizing for women's bodies. Other mechanisms for reducing infections, such as mechanical ventilation or air filtration, should also be available, protecting all without gendered variance. And I know that it is repetitive of what my lady has already heard in previous modules. Thank you. We can take that down. Turning then to physical health, access to health and access to social care services. You tell us at paragraph 15 that, in general, women tend to report healthier behaviours than men. For example, healthier dietary choices and lower alcohol consumption, but that men tend to report engaging in more physical activity. Were those patterns reflected throughout the pandemic?
No, actually, what research has shown during the pandemic is that women's diet became poorer, with women eating less fruit and vegetables in general than men, and resorting to eating fast food and high salt and sugar food to a greater extent than that of men, and that women's physical activity also decreased compared to that of men. But with the first wave of the pandemic, when we went into lockdown, everybody's physical activity decreased.
Yes.
But men's physical activity returned to baseline quicker than that of women. We also saw that a trend emerging across the UK of alcohol consumption. Women reported drinking more during lockdown compared to men, who reported drinking less compared to baseline, compared to pre-pandemic levels. So this paints a picture of poorer everyday health of women during the pandemic. And I think that's important when we also think about women's mental health, because we know that diet and exercise and alcohol consumption can all affect mental health, and the sort of protective characteristics or protective measures that a healthy diet and healthy lifestyle have on mental health, and how that might then impact how women and men experienced the pandemic differently.
Yes, thank you. And we'll look at mental health in a moment. But first of all, access to primary and preventative health care. You tell us at paragraph 19 that it's well accepted in academic literature that women use GP services more than men. For example, in the UK, consultation rates are 32% lower in men than women. Was that also reflected across the pandemic, or is that something that you were able to look into?
So we don't have data necessarily about the change in utilization of gendered utilization of GP services during the pandemic, or at least not to my knowledge. It might be out there, but what's important to note is that when services were disrupted because of the pandemic, when they moved to telephone consultations, when they moved to reduction of provision in general, this will impact women more than men, because women are more likely to be the users of these services, mainly because of the fact that women are more likely to over a reproductive life course, are more likely to be engaging with health services. Because, like I said before, women are more likely to seek healthcare than men, for kind of behavioural differences.
Yes.
And women are more likely to be the ones taking children to GP services, taking elderly relatives, taking neighbours. So it affects women more than men if that provision is changed.
Interrupted,
anyway. Yeah.
Yes. Thank you. I'm going to ask you specifically about 5 areas of healthcare. Firstly, impact on breast cancer. You tell us at paragraph 20 that the COVID-19 pandemic significantly disrupted breast cancer screening services across the UK during 2020-2021, leading to delays in diagnosis and treatment. Did all 4 areas of the UK experience the same level of service disruption?
So we saw service disruption in all 4 countries, or all 4 nations in the UK, but
Yes.
to greater and lesser extents. It wasn't the same. And the ways in which, or the durations for service disruption and the mechanisms by which they sought to try and catch up some of that disruption were different in the different administrations.
Thank you. Next, cervical screening services. Were those activities suspended in many locations? And did you find that between April and June of 2020, the number of cervical screening samples received at laboratories in England dropped by up to 91% compared to the expected figure that before the pandemic, and taking that out of the equation?
Yes, it did. So we saw a significant, 90-something% drop,
Yes.
and then a significant effort to try and catch up again. But there still was a shortfall of about 6% overall. So there still was a gap from what would have been expected in that year, in those years, to what actually happened.
Thank you. What did you find in terms of prostate cancer diagnosis?
So again, there was a 30% reduction in prostate cancer diagnosis, and there's increasing evidence now showing that when men were presenting, it was later stage because of the preventative screening efforts being suspended.
Thank you. You've mentioned menopause services. Were they also disrupted, particularly at the beginning of the pandemic? And were many routine and non-urgent services suspended for longer, including the cancellation of appointments, the redeployment of staff, and disrupted training for clinicians and other health professionals?
Yes, absolutely.
And again, was that the position across all 4 nations?
To the extent that we have the data.
Yeah, right. Is there a difficulty presented by a lack of data that's split into the 4 nations?
Yes, so the ways that all these screenings are measured and recorded is different in each of the devolved administrations, and therefore you're not always measuring exactly the same thing when you look at service
Right.
disruptions, when you look at what is being counted. Is it about, people coming in, people being invited, people, samples being received? There's multiple different ways of how and what is being considered between the different administrations.
Right. Thank you. And finally, on this topic, impact on elective care. Did you find that there was a 60% increase in waiting list times during the pandemic?
Yes, for gynecological services. So gynecology was the area of medicine and clinical practice that was most disrupted in terms of wait lists during the COVID-19 pandemic, with many of the services being considered elective and therefore, not urgent in the same way as other clinical specialities, and therefore it's the area which we've seen the greatest wait times, waiting lists now of over a year that still remain.
Right. So continued disruption.
Continued disruption.
Yeah. Thank you. Access to sexual and reproductive healthcare services next, please. You tell us at paragraph 26 that the closure of sexual and reproductive health clinics disproportionately affected women who are the biggest users of these services in the UK.
Yes.
And that approximately 1/4 of respondents to a national survey conducted online, including open text responses in the summer of 2020, reported that social distancing measures had made a difference to their access or use of such services. Is that right?
Yes, that's correct.
Changes in maternity services, care delivery and maternal death rates and interactions with healthcare providers. You've touched upon maternal death rates already, but is it right that maternity services as a whole were significantly disrupted by COVID-19, which led to widespread changes in care delivery and reduced interactions with healthcare providers for pregnant women, and an increase in risks, therefore, for women and babies?
Yeah, absolutely. So it's well established in the literature that multiple antenatal appointments lead to the best possible outcomes for mother and baby, which is why in the NHS we have so many routine appointments offered to women. Now, during the pandemic, many of such appointments were moved to telephone consultations, and therefore women weren't getting the same level of care, arguably, than they were prior to the pandemic. This is also true in the postnatal period. And one of the concerns has been that the impact this might have both on the physical health of mother and baby, but also on the kind of mental health and postnatal challenges that many women face, and the kind of perinatal mental health that might experience poorer outcomes as a consequence of this lack of engaged care, face-to-face care.
Yes.
In the antenatal period.
And the inquiry has heard and will hear again that also where face-to-face meetings and appointments did take place with pregnant mothers, they often had to attend those alone and without their partners.
Absolutely.
And that had an effect on their experience.
Absolutely. So, and I think it's important that we remind the inquiry it's not just those appointments that women were going to on their own, but also we saw significant limitations on birth partners being present during birth. And
Yes.
so women were having to give birth alone. And I think that is, it sends shivers down my spine just thinking about these poor women who are having to give birth alone, at the most vulnerable stage in their lives, arguably. And the fact that we know that, I think, I can't remember the exact statistics off the top of my head, but 70% of birth partners or 70% of trusts reported some limitations on birth partners' participation. And I think that's a really notable finding.
Thank you. And just to put some figures onto the evidence that you've just given, at paragraph 29, you tell us that 53% of women in England with recent experience of maternity care felt that they had experienced changes to their care during COVID-19, and 35% had antenatal appointments cancelled, 32% of women experienced changes to their plans for birth, and 50% of women stated that they wanted more midwifery contact in the postnatal period.
Yeah, and I think also just to add, if the service provision isn't there, then women might turn to their family, friends and community for such support. But if that was also being limited, then I think there was this real impact of women, going through birth, postnatal periods very much on their own.
Yes. Some of the reasons that you give for poor experiences during the pandemic, particularly in relation to women, are structural and systemic discrimination, racism, bias in health settings, fragmented care, and poorer baseline health caused by socioeconomic inequalities. How should that have been planned for and prevented? And what steps do you think, Dr. Wenham, can and perhaps should be taken to ensure that those experiences are not repeated in a future pandemic or other health emergency?
Well, so, the social determinants of health that you outlined, the fact that we know that, people from lower socioeconomic groups, people who are ethnic minorities in the UK are more likely to experience poorer health outcomes isn't new, right? And that's not because of the pandemic, that's just in general. And so knowing that and then planning for your pandemic policy or your pandemic response, taking into account these factors, to me should be a given, because it's routine activity in a health system to understand that the most vulnerable in society are the ones who are going to experience any health issue with poorer outcomes.
Yeah.
So putting that front and centre, recognising those inequalities. I think that there's sometimes a tendency to want equality for everybody and therefore write neutral policies as if everybody experiences, or everyone should have the same opportunity to the same outcome or to the same access to services. But actually recognising the limitations and the barriers of accessing those services are different between different people, and therefore service provision needs to look different for different people is a really important lesson that should be learned, although indeed health services know this because they do it on a day-to-day basis. It's just recognising that that's not just in the routine, but it's also in the emergency.
Yes.
That, case numbers aren't just case numbers. Those are people who experience life, interactions with health services, interactions with all social services in different ways to each other.
One of the measures that was taken, an emergency measure, I suppose it could be described as was a change in relation to abortion provision, wasn't it, in England and Wales? Tell us about that, please.
So prior to the pandemic in England and Wales, you had to have a face-to-face appointment with a medical professional to obtain medical abortion tablets to be able to perform a medical abortion. It had to be taken in a clinical setting. Now, this elsewhere, including in Scotland, it was allowed to have, prior to the pandemic, you were able to take this medication in the privacy of your own home, and there have been no safety concerns linked between taking such medication in a clinical setting or a home setting. Indeed, globally, in many parts of the world, you can take this safely at home. In England and Wales during the pandemic, mechanisms were changed to allow women to take the medical abortion tablets in their own home to try and reduce the interaction with the health service in the clinical settings and reduce the burden on the health sector at that time. And it has been, it has now allowed women to have an determination on their own terms in their own home, and it's something which has continued subsequent to the pandemic as well.
Thank you. Turning to look at formal and informal social care, please. You tell us at paragraph 36 that this disproportionately impacted women. And you also talk about caring responsibilities, that 80% of adult social carers are women, and that ethnic minority women are overrepresented in paid and unpaid care roles. You then go on to tell us that migrant women and those with no recourse to public funds were working in the care sector and therefore at particular risk with no alternative than to work and therefore increase their exposure to risking catching the virus. And you go on to say that women, particularly older women or those with disabilities, were more likely to rely on formal care. You don't comment on disabled women living in their own homes or other settings. Are you able to provide any comment on the impact on disabled women as recipients of domiciliary care or indeed unpaid care? For example, disabled women living in their own homes who used and relied on formal and informal care services.
So we don't have, or I don't have, data to give you a very clear picture on that, but we have to assume that the same is true, which is if there's a reduction of service provision, it will affect disabled women or indeed anybody in receipt of such care, whether they are in formal settings or in domiciliary care. The same impacts will be true, that women are the greater users of such services and also the providers of such services. So any disruption affects both supply and demand of those services for women.
Thank you. Yes. And for disabled women who relied on domiciliary and unpaid care in their own homes, in your opinion, would the impact of domestic abuse on disabled victim survivors be compounded by the fact that their perpetrators were often their carers and during lockdown would often be their only carers?
So again, I don't have any evidence to be able to give you an affirmative answer to that question. However, we do know that disabled women are one of the most vulnerable groups from a domestic abuse standpoint, and therefore it is likely that if it is those carers who are their abusers as well, then that would pose a significant risk. But again, I don't have any data to point to that precisely.
Thank you. Turning away from healthcare now and towards finances, conscious that this was the subject, really, business and finance of Module 9. I'd like to ask you about pre-existing inequalities going into the pandemic. Is it right, in your opinion, Dr. Wenham, that women were more likely than men to lose jobs, to be furloughed, or to reduce paid hours during the lockdown?
Yes, and I think, if I may, there are sort of three reasons as to why women might have experienced that differently to men.
Yes.
The first one being that women are more likely to be working in sectors of the economy that were shut down first, so in the education, in retail, in hospitality. Those are feminised sectors of the economy in the UK, and therefore, when they closed, women's employment was more at risk. We also know that women are more likely to have shouldered the unpaid care burden within households when school closures has occurred. So you might have taken a step back from your paid employment to look after your children, for example, or a reduction of hours to be able to facilitate homeschooling. And that's partly dependent because of gender norms in the UK, but also partly because of the gender pay gap. And if you're in a heterosexual couple with dual earners, you might choose the person who earns the most to keep full-time employment, and the person who earns the least, which tends to be the woman, to reduce hours or stop working.
Thank you. The inquiry has heard about the uplift to universal credit. You tell us at paragraph 43 that the number of universal credit claimants rose by 90% between March and October of 2020, with 2.2 million new applicants in the first 2 months alone. Did women struggle, though, to access timely or sufficient support such as universal credit? And if so, why do you think that might have been?
Well, so for example, we know that the single household payment was an issue. We know that particularly those who are on low income, who are in precarious work, or single parents might have struggled with such a payment mechanism. And it's also a risk factor for domestic abuse that we know we'll come on to later on in our conversation. But that, the power around resources is also something to bear in mind at this point.
Thank you. You then go on to discuss disabled women, and you say that they experienced sharp economic shocks and reduced access to support. And at paragraph 46, you say that Black, Asian and minority ethnic women were more likely than white women or Black, Asian, minority ethnic men to report income loss, difficulty affording essentials, and increased caring responsibilities. And importantly, in your opinion, many disabled men and women were in receipt of legacy benefits, such as employment and support allowance, which were excluded from the £20 uplift applied to universal credit, and that policy decision created what you describe as a two-tier system of support during the pandemic, thereby deepening existing inequalities and leaving disabled women on legacy benefits at greater risk of financial hardship.
Yes.
What impact did the two-tier system of support that you describe have on disabled women? What effect might that have had on their existing inequalities? And were there additional risks identifiable for disabled women as a result?
Well, so, I mean, again, that comes up again and again in every sector of this report, and indeed my previous evidence. It's the intersecting nature of all these issues. So the compounded vulnerabilities that different women across society face, create greater inequalities and discrepancies. Now, the chances of the people who were still on legacy benefits being those most vulnerable in society is high. The ones who are, least likely to be able to actively move on to a new payment mechanism, for example. I think it's also important to note that the new challenge experienced by disabled women from a finance perspective was the fact that they might not have been able to go back to work with the same readiness as their non-disabled counterparts, particularly if they felt they were clinically vulnerable and didn't want to go back into a workplace when the reopening occurred because they were worried about their own health, for example. And so this creates a compounded vulnerability for their finances if actually that means they're then continuing on less pay or on reduced hours, or indeed lose their job because they are unwilling to put themselves at greater risk being in a public setting.
Thank you. At paragraph 52, you tell us that for migrant women with no recourse to public funds, the effect of income loss was even more severe, and that many, as we've already established, worked in insecure sectors such as care and cleaning, yet, as we know, were excluded from furlough, universal credit and housing support. Just to reflect on what was being said at the Domestic Abuse and Safeguarding Round Table, could we have a look at the summary report, please? INQ 000587973. Yes, thank you very much. Could we go to page 5 and highlight paragraph 11 on this topic? Thank you very much. The pandemic had specific impacts on some groups of victims and survivors. For example, victims and survivors with no recourse to public funds and migrant women faced difficulties accessing online or telephone support available during the pandemic. This was because they lacked the means to purchase telephones or data, access Wi-Fi or other technological equipment. They also faced language barriers and were fearful that information shared online could be sent to the authorities and affect their immigration status. Without British Sign Language interpreters for government messaging, deaf victims and survivors didn't receive basic information about the rules and restrictions, which representatives said perpetrators took advantage of to control victims. Domestic abuse and safeguarding workers, as well as interpreters, were also not considered key workers and therefore unable to provide support in person to victims and survivors. And that seems to chime with the research that you were conducting and the results that you were getting, Dr. Wenham.
Absolutely.
Thank you. Turning to housing, please. You tell us at paragraph 56 that in England, only 2% of white British households were officially overcrowded before the pandemic, compared to 24% of Bangladeshi, 18% of Pakistani, and 16% of Black African households. What happened during the pandemic, and in particular, did you find that elderly South Asian women in multi-generational households were at significantly higher risk of dying from COVID than others?
Yes, and so again, this is not my research, but research by Nafilian and colleagues showed that elderly South Asian women were at greater risk of dying from COVID, and they attribute this to spending greater time in an overcrowding home and performing caregiving roles, making them, more at risk of household transmission of disease.
Thank you. And in terms of homeless women, at paragraph 59, you tell us that while men made up the majority of rough sleepers and were thus more visible in public discourse and policy responses, women, who account for around 60% of statutory homeless households, were more likely to experience hidden homelessness, such as sofa surfing or remaining in unsafe domestic situations. And as informal living arrangements collapsed, frontline workers reported rising numbers of women requiring urgent assistance, including survivors of domestic abuse.
Yes.
In considering the impact of lockdown restrictions, let's go back momentarily, please, to have a look at the Domestic Abuse and Safeguarding Roundtable Summary Report, and in particular, paragraphs 59 and 60, to see what was being said during the course of this particular roundtable. Well, representatives said that they had significant concerns about the impact of the pandemic on access to safe accommodation. The pandemic restrictions and social distancing measures resulted in reduced capacity at many refuges, making it difficult to accommodate those in urgent need. And furthermore, according to the representative for the Local Government Association, there was uncertainty in how refuges could operate while following restrictions, particularly around contact between people from different family units. Before the pandemic, Southall Black Sisters and Solace Women's Aids operated an open door policy, but they had to stop this during the pandemic, and this affected some victims and survivors from accessing safe accommodation. The demand for safe accommodation during the pandemic was greater than the accommodation available. Solace Women's Aid saw a doubling of referrals to refuges between early March and the end of April 2020, which was a challenge to accommodate. And the representative for Mankind Initiative said that the increase in demand for safe accommodation could not be met because of a lack of availability, compounded by those already in safe accommodation having nowhere to move to during the pandemic. Finally, before leaving this topic, please could we display the Shadow Pandemic Shining a Light on Domestic Abuse During COVID report. It's at INQ 000 475 125. I think that you've had an opportunity of looking and considering this report, Dr. Wenham. And could we scroll down, please, to the second page? We can see here that the researchers and authors come from all manner of, thank you very much for highlighting that, all manner of relevant organisations. And then if we could turn to page 49, please, and highlight the first two paragraphs under 7.1.5. We can see here COVID-19 has had a negative impact on women's housing situation. For many women living with their perpetrator, the introduction of lockdown would have meant being trapped at home almost 24 hours a day with their perpetrator. A Women's Aid survey investigating the impacts of the COVID-19 pandemic with women victim survivors found that perpetrators used COVID-19 as a tool for abuse in connection with their housing situation, refusing to take precautions to stop the spread of the virus and or forcing their household to live under unnecessarily strict measures and making it harder to flee. And that perpetrators' use of economic abuse further destabilised women's housing situation during the pandemic. This may include restricting, exploiting and or sabotaging housing and accommodation. And a survey carried out by Surviving Economic Abuse found that over a third of women's housing situations had worsened because of perpetrators' actions since the start of the pandemic. This same survey found that prior to the pandemic, 14% of women were in rent or mortgage arrears because of perpetrators' economic abuse, and that this had increased to 25% since the start of the pandemic. So thereby bringing together the influence on both the financial aspects of women's lives and also the housing situation, particularly of those women who were being subject to domestic abuse.
Absolutely.
Thank you. You can take that down, please. In your view, Dr. Wenham, what learnings should be embedded in future emergency plans to prevent a repeat of the disproportionate health harm borne by women, and in particular homeless women?
Well, I think it's about recognising that this shouldn't be an afterthought, right? And that, you know, if you're asking people to, in this instance, stay at home, then we have to recognise that, you know, home and housing is a vital part of that. And for many women, that is not a safe place or not a secure place. And therefore, building into pandemic planning or emergency planning the realities of how women experience safety and security within their homes should be, you know, a paramount part of the planning phase and not a second thought, which is what happened during the pandemic.
Thank you. I want to touch very briefly, please, on skills, training, apprenticeships and education. At paragraph 73, you tell us that the COVID-19 pandemic disrupted adult education and training across the UK, affecting both apprenticeships and other further education pathways for learners aged 19 and over. How in particular did that affect women who were hoping to train or join an apprenticeship?
Well, so again, it falls down intersecting lines. So, you know, women who also have other intersecting inequalities or vulnerabilities may have experienced this to a greater extent. One of the key ways we saw this was through additional care burdens that women were facing. So they weren't necessarily able to continue with education or their training if they also had to assume childcare responsibilities or community care or elderly care responsibilities. We also know that there were tensions around access to remote learning and digital engagement with gendered and age-related and socioeconomic group status differences in access to digital tools to be able to move online for such education and training opportunities.
Thank you. And at paragraph 90, you tell us that unpaid childcare responsibilities and homeschooling affected women's well-being more than men, and there were increased rates of anxiety and depression reported amongst women compared to men in relation to unpaid care within the home. And you go on to say that single parents, approximately 85% of whom are women, particularly suffered from increases in unpaid care work during the pandemic. These women have consistently reported increased concerns of financial insecurity, risks of falling into poverty, and increased mental health concerns because of that.
Absolutely, yes.
Yeah. Evidence from your report indicates that women, especially racialised women, reported larger and more persistent declines in mental well-being than men during the pandemic, linked to heightened loneliness, as we've just seen, heavier unpaid care and service disruptions. Was this an exacerbation of structural inequalities that were already present before the pandemic?
Absolutely.
Yeah.
So we know that women are more likely to experience greater anxiety than men. We know that women are more likely to, during the pandemic, have suffered greater sense of isolation and loneliness. Women tend to have more friends and bigger social groups than men, and therefore when restrictions on social mobility came in, that tends to affect women's engagement with friends, family, more so than men, who are more likely to have fewer and smaller close-knit friend groups. I think you also have to take into account that, for example, if you were starting to, when restrictions eased and you're able to meet up with people, when the rule of six, for example, came into play,
yes.
If you are also a primary caregiver, you have to count your children within that rule of six. It meant you could meet up with fewer people at a time. Obviously, the more children you have, the fewer people you can meet up with at any one time. And so there are these differences in how women were able to engage and maintain friendships and social interaction, and things that we know are protective factors for mental health, isolation and loneliness.
Thank you. We've touched upon it already, but I want to ask you now about exposure to violence, please, and the impact of the pandemic on new forms of domestic abuse. You tell us at paragraph 93 that COVID-19 exacerbated existing risks of and exposure to violence against women and girls, and that lockdown measures, economic instability, social isolation and distancing created conditions which intensified the likelihood of violence occurring in the first place, and in turn limited women's access to support services. But what were the new forms of domestic abuse that your research disclosed that happened during the course of the pandemic?
Absolutely. And I should say this isn't my research, but research from others in my field. And I know that you've got another piece of evidence, a witness
Yes.
this morning, who's much more of an expert in this than I am. But the research summary that we have is that there were new forms of violence and abuse, such as exploitation of pandemic fears. So abusers not being willing to engage in social distancing, not being willing to wear a mask, coughing on victims, for example. We also know that there was abuse related to access to technology, and whether victims were able to, speak to their friends, speak to their family, use a telephone, use internet. And then access to treatment and food, which was obviously not as easy if you were at home rather than in normal society, as another way of controlling and coercing victims.
You set out at paragraph 96 some statistics in relation to domestic abuse rates. You say that by April of 2020, Refuge, the UK's largest domestic abuse charity, had reported a 700% increase in calls to its helpline in a single day, and that by May 2020, the charity had reported a 957% increase in web traffic. That by June of 2020, Marie Stopes International reported a 33% rise in domestic violence reports related to seeking reproductive services. That the National Domestic Abuse Helpline received 40,000 calls in the first 3 months of the first lockdown, an 80% increase on pre-pandemic figures. and that rape crisis centres reported a 41% increase in sessions of specialist support between 2019 to 2020 and 2020 to 2021. Some shocking statistics there.
Yes, and I would just add, though, that we have a tension in the measurement and data around domestic violence. And again, the next witness, I'm sure, is much more able to speak to this. But we know it's a very underreported issue,
Yes.
and therefore we have to rely on proxy indicators such as calls to helplines or web service traffic or administrative data such as police records to try and give an indication of trends that are emerging. But it's very hard to get accurate statistics because of the clandestine nature of domestic violence and abuse and the challenges that women face in reporting such abuse.
Thank you. And this, in fact, is reflected in the information that was provided to the Domestic Abuse and Safeguarding Roundtable. Please, could we have a look briefly at page 4, paragraph 4 of that report? Thank you very much. Reports of domestic violence to the police were low at the start of the pandemic, given victims and survivors were either unable to report as they were trapped with their perpetrator, or because they were not sure if it was possible to report to police during a public emergency. However, reporting figures increased as lockdown restrictions began to ease, and representatives felt that the level of reporting did not reflect the actual number of domestic abuse incidents during that early pandemic period. Although domestic abuse often goes unreported, they thought even fewer people were reporting offences during the first lockdown, as emergency services were overwhelmed or support was not available. Yes, thank you very much. At paragraph 99, you tell us that in the UK, in the first month after the initial lockdown, the rate of homicide in women was more than twice the average of 2 women a week, and the highest rate in the last 11 years, but that such a trend did not continue over the course of the pandemic, with domestic homicides, the majority of the victims of which are women, and the crime committed by men, not appearing to have increased substantially, but that since 2021, Northern Ireland has the joint highest rate of femicide in Europe and the highest rates of domestic violence in the UK.
Yes.
Thank you. Let's go back to your report, please, and reminding ourselves it's INQ 0000657 and have a look at paragraph 104, which is at page 37 to page 38. Thank you. It begins at the bottom of page 37, and this is where you draw together all of the evidence that we've just considered. Domestic violence should have been considered as a likely consequence of lockdown measures from the start. You say recommendations for the future could include the following: early recognition of the impact of pandemics and lockdowns on domestic abuse and the particular risks faced by those women from Black, minoritised, disabled and migrant communities and those with no access to public funds. Domestic violence support mechanisms excluded from social distancing and lockdown provision from the start, so that there is safe refuge for victim survivors. That there's early planning, consultation and engagement with the violence against women and girls sector, including increased funding to domestic violence charities in the early stages of a health emergency to facilitate additional provision of care and support for victims and potential victims. That there's clear, accessible and translated messaging that those experiencing domestic abuse are permitted to leave their homes, and about safeguarding duties and statutory rights of those feeling abuse. That there's training of community members to identify risk behaviours such as postal workers, community workers and others that may visit door to door routinely, and greater investment in domestic violence mitigation strategies in routine times to mitigate potential challenges at a time of crisis. This can involve, you say, working with potential abusers to identify the root cause of their violence. Is there anything that you would like to add to that, Dr. Wenham?
Well, I just think in general, these, the domestic abuse and violence discussion during the pandemic is that it's a challenge of supply and demand, right? Which was the demand for such services dramatically increased. Now, we don't have the actual data as we've talked about because of limitations, but we know there was an increase in demand for such services, but supply and provision of such services were reduced because of social distancing and restrictions in interactions, and that just seems counterintuitive. And at a time of crisis going forward, once we know demand is going to increase, and I note and I remind the inquiry that other health emergencies prior to COVID saw similar challenges around domestic abuse and violence. So it was a known outcome. Yes. And so therefore, supply should match demand. And so it's about increasing service provision and increasing support of such services to victims of domestic abuse and increasing supply of available safe housing, available safe spaces, available care to victims so that as demand goes up, we have the necessary supply to match it.
Thank you. The final topic I want to discuss with you is mental health. I know that you were specifically asked not to cover that because we had our own systematic evidence review underway. But we have touched upon it briefly, and I just would like to display the part of the systematic evidence review which deals with mental health and gender. Thank you very much. For the record, it's INQ 000659787. And could we turn, please, to paragraph 3.2.2, which should be begin at page 30. Thank you very much. So this section examines gendered differences in mental health and well-being across the pandemic period. Evidence is moderate to strong, with multiple large, high-quality UK longitudinal studies consistently showing that women experienced worse mental health outcomes than men, both before and during the pandemic. And if we can move down, please, to see how this is reflected across the time periods. Thank you. The pre-pandemic baseline. So prior to the pandemic, women consistently reported poorer mental health than men, including higher levels of anxiety, depressive symptoms, loneliness, and lower life satisfaction. Studies found that women had higher levels of symptoms such as tiredness, insomnia, trouble concentrating, and psychological distress across different groups based on their health behaviours, such as drinking and eating habits, which we've touched upon. Moving into the initial lockdown period, thank you, we can see that during this period, women on average spent significantly and disproportionately more time on childcare and housework than men. This included unpaid care responsibilities, including housework and homeschooling. Some women also reported a sharp decline in their ability to enjoy everyday activities, and mothers in particular reported doing less physical activity. This reduction in physical activity was associated with worse mental health outcomes for mothers, as doing less exercise during lockdown was associated with a higher chance of depression and anxiety. Then the next period of time is entitled Easing and Summer. That's July to October 2020. Women experienced a slightly greater reduction in average psychological distress compared to men, suggesting some short-term improvement, but this was compared to a higher baseline level. And then moving to the second, third lockdowns and winter, November 2020 to March 2021, we see that the reintroduction of restrictions during the second and third lockdowns was associated with a renewed deterioration in mental health, and that one study reported that women's mental health worsened than men's during this period. And if we go finally, please, to the easing and post-pandemic period, which is April 2021 to May 2023, we see that mental health symptoms declined following the easing of restrictions, indicating a partial recovery. However, distress levels remained higher than before the pandemic throughout this period, and that women continued to report higher symptom levels than men. Can we assume, Dr. Wenham, that may have been for all of the reasons that you've set out in your evidence this morning?
Absolutely. I think, I think that there must be, or it's important to look at the variation between the women in these different sectors, right? Because you've talked about mothers, for example, compared to women. And I think we need to recognise the different ways that mental health and anxiety were going to be experienced by different types of women during the pandemic. So if you are also homeschooling and working and as a single mother, you're going to experience much poorer mental health outcomes, for example, than if you are a woman with no children who's able to work at home and, affluent enough to not be worrying about financial challenges. And so I think, again, it's important to disaggregate who it is that are being considered in each of these samples. But yes, it's consistent with all different parts of this report.
Thank you. We can take that down, please. You set out lessons learned, recommendations across the whole of this piece of work at paragraph 112, and many of these we have already covered during the course of your evidence. Is there anything else which you would like to add to the recommendations that you have already made about the improvement of the plight of women for next time?
Well, I think, most of it's all set out, and I don't want to repeat it all for the sake of repeating it, but I think it's important to note that women aren't a homogenous group and that different women are going to experience any health emergency or other crisis in different ways. But I think that the tendency towards neutral policy making obscures these differences of how women experience life in society in the UK or indeed anywhere in the world, and that recognising the real life implications of every policy, every action is vital to actually understanding how such a policy will work. Because if women aren't able to, survive, to afford to eat or feed their children, or not experience severe mental health outcomes, they might not then engage in the policy in the same way. And so if you're looking to stop a health emergency, you want everybody engaging in that policy. And so recognising the limitations on people's engagement, on women's engagement, is actually a good public health measure, because it can lead to better adherence and uptake of future policies and future public health requirements in a health emergency. So it's not just about gender, it's about getting better public health outcomes because you recognise the realities of people's lives in our society.
Thank you. No. Dr. Wenham, thank you very much for your evidence this morning. My lady, you have given permission for Mr. Pezzani on behalf of Mind to ask a question, and so may I ask him to do that now?
Mr. Pisani.
I'm very grateful. Dr. Wenham, good morning. Roger Pisani asking a single question on behalf of Mind. This, I think, relates to your point about supply and demand. We understand that routine mental health care and access to therapy were restricted during the pandemic, and just as many women's mental health needs increased during lockdown. Different reasons for different women, as you say. Women are not a homogenous group. But for example, in relation to postnatal mental health care, mental health impact of unpaid care, financial and housing insecurity, loneliness and isolation, and domestic violence, as just exemplars. The question is, based on your research, how do you consider the service disruptions and contractions impacted on women's mental health needs during the pandemic?
Well, I would add that I wasn't asked to comment on the mental health in particular, so I haven't got a section in my report on mental health. But it would be part of the multifaceted landscape you've just described of the different reasons of why women were experiencing poor mental health, and then their inability to access services may have compounded each and any one of those. But again, I don't have any data to back up that point. It would just be my expert opinion based on the variety of other challenges that women faced from a mental health perspective.
I see. Thank you very much.
Thank you, Mr. Pisani. Dr. Wenham, that concludes your evidence. Thank you so much for the help you've given to the inquiry, both in the last module. Is it module 2?
Yes.
I'm losing track of time now. And in this module, I'm really grateful to you. Some very interesting information you provided and expert opinion. So thank you for your help.
Thank you.
Very well. I shall break now and return at 5 to 12.
Thank you, my lady.
So I'll wait for the chair to come up on the screen.
Yeah.
And then council will ask if you to be standing.
Ms Blackwell.
My lady, can you see and hear me?
Can, thank you.
May I call the next witness, Miss Gisela Ballet?
Would you like to stand, please? Take your Bible in your right hand and repeat after me. I swear by Almighty God
I swear by Almighty God
that the evidence I shall give
that the evidence I shall give
shall be the truth,
shall be the truth,
the whole truth,
the whole truth,
and nothing but the truth.
and nothing but the truth.
Thank you. Take a seat.
Thank you.
Thank you. Will you give your full name to the court, please?
Yes, Gisela Valle Garcia.
Thank you. And Miss Ballet, you should have in front of you a copy of your witness statement, which bears our reference number INQ 000652188. Can you confirm, please, that this is the witness statement that has been provided jointly on behalf of the DA Group organisations for the purposes of Module 10?
That is correct.
Thank you. And can you also confirm that any facts stated within the witness statement are true to the best of your knowledge and belief?
Correct.
Thank you. I'm going to begin by providing a description of the registered charities which contribute to the domestic abuse group. The first is the Southall Black Sisters, which is a black feminist organisation founded in 1979, dedicated to empowering black, minoritised and migrant women and girls, particularly those fleeing violence against women and girls. For over 4 decades, it has been advocating for the rights and safety of some of society's most marginalised women and provides counselling, support groups and education classes in London and conducts policy work, campaigning, research, professional training and community education and development.
Correct.
Solace Women's Aid was established over 50 years ago and is one of the single largest providers of services for victim survivors of violence against women and girls in the UK. It was established to prevent violence and abuse and provide services to meet the individual needs of victim survivors, predominantly women and children. Its mission is to end the harm done through gender-based violence and to work alongside victim survivors to achieve independent lives free from abuse. And it is the lead agency in several partnerships across London, delivering domestic abuse services, including advice, advocacy, refuge, resettlement, counselling and therapeutic support and children's support. And it operates 24 refuges. And it adapted in the pandemic to maintain all refuge provision whilst adapting community and therapeutic services to be delivered remotely.
Correct.
During the pandemic, Southall Black Sisters and Solace Women's Aid launched a crisis project offering safe emergency accommodation with specialist support to women and children across London during the pandemic, and it provided accommodation and support to 205 women from May 2020 to September 2021, including 73 who had no recourse to public funds. You, Ms. Ballet, are director of the Latin American Women's Rights Service, which was founded in 1983 by a group of Latin American women who saw a gap in the services that existed for women migrating to the UK from Latin America. And in the 42 years since its inception, it has supported the practical and strategic needs of Latin American migrant women, as well as black and ethnic minority migrant women nationally facing intersectional violence and discrimination shaped by their race, class, gender and immigration status. It established an advice, information and advocacy service to inform women of their rights and enable them to access services in a culturally, linguistically and gender-specific setting. And during the pandemic, your organisation adapted its services to remote delivery to ensure continuity of support for Latin American and migrant women experiencing violence, and provided essential information about COVID-19, about rights and access to services in Spanish and Portuguese.
That is correct.
Thank you. One of the key impacts of the pandemic for victims, survivors of domestic abuse was as a result of lockdown. And we know from your statement that the impact of lockdown impacted victims, survivors of domestic abuse in multiple, often overlapping ways. I will ask you about those impacts as we go through your evidence, Ms. Ballet, but can I first ask you about the impact of the pandemic and lockdown on domestic abuse levels and trends? At paragraph 27 of your report, you tell us that the impact of the pandemic and that of lockdown were interrelated, and yet each also had distinct effects, as well as cumulative impact. Yep. For victims, survivors of domestic abuse, it was often the combination of the pandemic and lockdown that amplified that abuse. Is that right?
That is correct.
And at the same time, the pandemic introduced more subtle dynamics of abuse, of control and patterns of abuse, allowing an abuser to exploit, for instance, fears of infection, restrictions of movement, and to further isolate or control victim survivors.
Yeah, that is correct. I think, just to add a little bit to that, domestic abuse gets to thrive in situations where there is no hope of disrupting the dynamics of power and control at the center of domestic abuse.
Yes.
So we had the pre-existing barriers experienced by certain groups more than others, but then the pandemic itself and the lockdowns introduced new barriers and systems. And I think the reason why we saw the jump in the demand for the services that we saw is precisely because once perpetrators were aware that there were new measures of controlling victims, they used them to full advantage. Once victim survivors were trapped in situations where they have no hope of contacting anyone outside of the home where the perpetrator was, it reinforced that dynamic. So the pandemic kind of adds fuel to the fire that already exists in situation of domestic abuse. It amplifies, it makes it easier, and it makes it a lot harder to exit that situation. And we saw that through a range of measures.
Thank you. And we'll turn in a moment to look at new types of abuse that were apparent throughout the course of the pandemic. But you also tell us that countries that experienced earlier outbreaks of the pandemic to the UK, such as China, Germany and Italy, began reporting rises in domestic abuse before similar trends emerged in the UK. And that was reflected in the overall increase in reports of domestic abuse that all three of the DA Group organisations, as well as others in the violence against women and girls sector, saw.
Yes.
Is that right? Because all three DA Group organisations experienced significant increases in demand for their support services during the pandemic, creating cycles of fluctuating demand that were characterised by what you describe as low footfall because of the pandemic restrictions, but high helpline calls. So was that something to which you had your organisations had to adapt?
Yes, I mean, it was two separate things. So one is, once the lockdowns are put in place, victim survivors are very aware that they're trapped in a situation with perpetrators. So we see the fluctuations going down because there's no way of making a phone call when somebody can listen to that conversation
Yes.
and enact retribution as a result of that. Of course, children are also in the house. I mean, everything is set up in a way that will restrict the ability of survivors to come forward and say, we need help. As situations start easing, of course, there's opportunities for these survivors, including women and others who are experiencing domestic abuse for the first time, to come forward and say, this is what's happening to me. I think at the same time, the low footfall during the lockdowns leads to another dynamic, which is women who realize that the risk of staying home is much greater than the risk of, for example, failing to comply with regulations, then just decide to take the case. So we see less cases, we see higher risk, and then once those restrictions ease, then we see that jump in demand for services.
And we've just heard from Dr. Wenham this morning that in terms of the level of domestic abuse complaints or the calls for assistance in terms of domestic abuse, it's that there is a danger of simply looking at the figures without understanding the underlying factors that may lead to more women feeling able to ask for support and make complaints, and the numbers not necessarily really reflecting what's going on at the time. Can we look, please, on this topic at the Domestic Abuse and Safeguarding Roundtable report? It's INQ 000587973. I think, Ms. Ballet, that you were present at the roundtable, were you not? That was split into two sections. There were national groups, and you were present at the, I'm going to call it the specialist section
Yes.
of the procedure. And let's look, please, at what's said about the impact on reporting domestic abuse to the police. It begins at paragraph 24. The increase in intensity of abuse during the pandemic was not initially reflected in increased reporting to the police or an increased demand for domestic abuse support. Representatives stressed that low levels of domestic abuse reporting to the police were not unusual before the pandemic. They said that many victims and survivors do not report domestic abuse or pursue cases, and victims and survivors often do not report domestic abuse incidents immediately after they occurred. For these reasons, there are significant gaps in knowledge relating to perpetration of abuse. And there's an example given there by the Welsh Local Government Association. A person experiences domestic abuse maybe 10 times before they will report it. It depends where someone is on their journey. You can go from someone who has lost their temper and there is one incident to someone who deliberately has a campaign of abuse. And if we read on, however, as lockdown eased, there was an increase in reporting of domestic abuse and referrals to support services. Representatives saw this as an indication that perpetrators had been exerting greater control during periods of lockdown restrictions. They also attributed this increase in reporting as restrictions eased to victims and survivors not knowing whether they were able to report domestic abuse during an emergency or if the police would be able to do anything about their situation given the lockdown. This pattern of increased reporting continued, with the representative for Rape Crisis England and Wales noting that in 2021 to 22, that saw the highest annual figure of recorded rape offences in England and Wales to date. I just want to go now to paragraph 28, please. Finally, on this topic, government agencies and legal and justice services reflected that one adaptation which proved effective during the pandemic was the transition to online court hearings for domestic abuse cases, particularly for non-molestation orders, as victims didn't have to be in the room with their perpetrator. However, this was not sustained, and most courts have returned to in-person hearings. And we'll look in a moment at the impact on justice for those who were complaining of domestic abuse. Thank you. We can take that down now. I'd like to take you, please, to paragraph 37 of your report and to talk about wider sector trends in reporting. Thank you. If we look at what's set out at paragraph 37, you say that the picture is complex, with organisations recording different figures during the change in non-pharmaceutical interventions. But the overall and significant increase in rates of domestic abuse and demand for frontline services was, in fact, sector-wide. The report by Women's Aid Shadow Pandemic Shining a Light on Domestic Abuse During COVID, which we've looked at in part this morning, shows the following. Refuge reported a 61% increase in helpline contacts during the pandemic compared to the pre-pandemic baseline. They went from about 10,500 visits per month in the first 3 months of 2020 to an average of 73,595 per month between April 2020 and February 2021, which was a 7-fold increase. The National Domestic Abuse Helpline logged 40,397 calls between April and June 2020, which was a 65% increase. Victim Support reported that in May 2021, the number of referrals received for victim survivors of domestic abuse was 25% above, and rape was 23% above volumes of the same referrals received in early 2020. That in the first 3 months of lockdown, calls to the National LGBT Plus helpline increased by 50%, with use of the web chat increasing by 30%, and that the charity IMCAN reported its members saw increases in referrals between 60% and 300% during the first lockdown. Now, these figures chime very much with the figures that Dr. Wenham has given us during her evidence this morning. And finally, Surviving Economic Abuse reported an 85% increase in website traffic, and a year of MARAC data collected by Safe Lives for 2020 shows increases in cases heard during lockdown periods, followed by sharp increases during the following quarter, demonstrating the potential impact of restrictions on support provision processes.
I think it says, sorry to interrupt, Ms. Butler, I think you said increases and it says decreases.
Oh, I'm so sorry. Yes, you are right, my lady, of course. Yes, decreases in cases heard during lockdown periods. And we'll look at that in a moment when we come to the justice sector. But taking those figures together, what did your organisations discover about the effect of domestic abuse, wider reporting trends across the pandemic period?
I think it reinforced the notion that victim survivors are clearly very good at managing and dealing with risk. And what we're talking about is that where there are situations that increase risk for them, they will adapt to that situation. So as I mentioned, during lockdowns, you're trapped with the perpetrator. It's very difficult to have a phone call or to go outside to access support. So you're going to go to the next best thing, which is going to be the increase in use of chat services or online services or looking at websites and finding out information. As the possibility of going outside increases with the easing of the lockdowns, then the risk assessment will modify accordingly. Now yes. I can go outside, now I can go and talk to someone, now I can get a referral to services. And that's what survivors do. So once either the survivor or the perpetrator is able to freely leave the house, then they will take on the first opportunity to come forward. I think probably the most problematic aspect has to do with the statistics by the police, because there is a significant question around why survivor services are seeing this movement that the police is not seeing. The figures remain flat. And that actually talks about how different groups, for different reasons, do not have trust in coming forward to police. If you add to that the fact that restrictions are changing and the rules are constantly changing throughout this period, there's no clarity around where domestic abuse survivors are sitting in the level of priorities that the police and other statutory services have at that moment, it's very easy to understand why we're seeing fluctuations as survivors are managing risk, but the police are not seeing those fluctuations. And for me, perhaps the key thing about this is that police being a primary, first responder in situations of high risk, it begs the question as to what measures should have been put in place at that point to enable police to continue performing that function. I'm just going to finish by saying that, of course, different groups are going to be affected by all this differently. Our beneficiaries, for example, are migrant women. They're subject to immigration control. They know it's not safe to come forward to statutory services because of data sharing and the involvement of immigration enforcement in their cases, not for safeguarding measures, but really for enforcing borders that might have consequences for them or their children in a variety of ways. But this is replicated across other groups. We know that deaf and disabled survivors, for example, have a massive struggle both with interpretation and also with being believed by statutory services. We know that the LGBTQ community is going to experience its own barriers. And perhaps the one thing that is missing here is a better understanding how these groups experience the situation in different ways. And more importantly, what measures need to be put in place to make sure that those who are most at risk can have the level of support they need to come forward.
Thank you. I'd like to look at paragraph 38 of your statement, please, which confirms the police and justice sector reporting patterns. You say that whilst calls to helplines increased significantly, calls to the police during this period were not increasing at the same rate, presumably for the myriad of reasons which you've just provided to the inquiry. You go on to say that unlike some European countries, the large increase in reports to police didn't happen in England and Wales. By mid-April 2020, police were informing the Home Office that the police recorded domestic abuse incidents were the same as they were in April of 2019, but they were aware of the difficulties of reporting domestic abuse to them because of the social isolation measures in place. Victim survivors of domestic abuse were not only deprived of opportunities to call the police, they were also fearful, as you have told us, of the potential ramifications of doing so whilst trapped in their homes with their perpetrators, and that migrant women with insecure immigration status faced additional barriers to accessing support due to the routine practice of data sharing between the police and the Home Office, when victim survivors reported abuse, stoking fears of deportation. So all of what you've just set out encapsulated there. Let's look, please, briefly before we move on at paragraph 40, please, of your report, where you give some figures. An Office for National Statistics report on domestic abuse prevalence and trends, year ending March 2022, found the following. No significant change in prevalence of domestic abuse experienced by adults aged 16 to 59 compared with pre-pandemic levels. Police recorded 1.5 million or so domestic abuse-related incidents and crimes in the year ending March 2022, which was an increase of just over 120,000 compared with the year ending March 2020, and an increase of 40,700 from the year ending March 2019. and that the number of domestic abuse-related crimes continued to increase, rising by 7.7% between March 2021 and March 2022, and which constituted a 14.1% rise compared to the year ending March 2020. Did this only provide a partial picture, though, in terms of the statistics that were collected by the ONS?
It does provide only a partial picture, because there is such a stark difference with what was coming through frontline services like ours and others nationally. But I say it's even more problematic than that, because while we had a massive struggle getting our data across to government departments in order to make decisions around pandemic measures and mitigation that could have been put in place for domestic abuse survivors, it's impossible for us to compete with the level of access. So if the police is saying nothing is changing, nothing is happening, the pandemic is having no effect on rates of domestic abuse and other forms of violence against women and girls, then the government will make decisions accordingly. I think it's really very crucial both to understand why in the context of a pandemic, again, your first responder and emergency service, you see no change in trends, and what that says about trust in the police generally, but also about the exclusion of the information that was vital at that time, coming from specialist violence against women and girls services. And I think it really gives a very good context as to why measures to support domestic abuse survivors take so long to come into place and really are quite limited in terms of the scope of what was needed to respond to the crisis in the context of a pandemic.
Thank you. Turning then to the specific impact of lockdown on victim survivors of domestic abuse. You say at paragraph 48 of your statement that existing structural inequalities shaped how individuals encountered both the virus and restrictions, explaining why lockdown effects were not experienced equally. And I'd like to display, please, the Women's Aid Shadow Pandemic Shining a Light on Domestic Abuse During COVID report from October of 2021. It's at INQ 000 475 125. We looked at this briefly, I think, with Dr. Wenham. Oh, I'm told, my lady, I'm so sorry for the delay. The screen is frozen. We don't need to display it. I can put to you the parts which I was going to take us to. The report states in the clearest terms that domestic abuse is a gendered issue in the sense that women experience higher rates of repeated victimisation, are much more likely to be seriously hurt or killed, and are more likely to experience a wide range of coercive and controlling behaviours. And we'll come to that in a moment as to how that increased during the case of the pandemic. The report also confirms that black and minoritised women are 3 times more likely to be in precarious and insecure work, often on 0-hours contracts, and less likely to qualify for furlough or statutory sick pay, and that Women's Budget Group, that organisation, estimates that without drastic action, the pandemic is likely to set back economic equality between men and women by decades. So the report really confirming that for women, domestic abuse during the course of the pandemic, really from start to finish, and particularly during lockdown, was a serious concern, and that the effects of the lockdown provisions that were introduced by the government also had a higher rate of effect for black and minoritised women than others in society. you say at paragraph 56 of your statement that the inherent nature of lockdown created conditions for perpetrators to exert control while creating challenges for victim survivors to seek support, which we've just looked at. And in terms of accessing informal support, did increased isolation from social networks created by the lockdown conditions create further abuse opportunities?
Yes, definitely. I think just thinking about a lot of the information that you have put forward, the key thing to understand is where Black, minoritized, migrant women and other disadvantaged groups are at the beginning of the pandemic.
Yes.
So for the beneficiaries that access our services, for example, we know that they are in overcrowded accommodation. They're going to have very precarious employment, usually no recourse to public funds, no access to healthcare services, and so on and so forth.
Yes.
So we already know that the conditions are there for, the increase in domestic abuse to happen, because a lot of avenues are already closed to them. As the pandemic comes on, you realize that if you're in precarious employment, for example, as a cleaner, you still have to go out there and you still have to work. In some cases, employers took the opportunity to reduce contracts, but then you still have no recourse to public funds. So the employer will decrease your income. The state will not supplement it in any way through furlough scheme or access to welfare benefits. You're going to be at higher risk because you are in overcrowded housing, and then you're under the control of the perpetrator. So that means that for these women, the risk of domestic abuse is much higher to begin with. It increases with COVID. And then you have all the opportunities that the lockdown and the pandemic itself presents to them. So either you're going to be at risk of infection, for example, if the perpetrator refuses to abide by the restrictions, or you're going to be at risk of becoming unemployed if, for example, the perpetrator decides to control your access to data, if you can work from the home, or decides to control access to money, and suddenly you can't be on public transport in order to go to your job, or will have control of the bank accounts, and so on and so forth. So the effects of all of these things happening, so the things that were before, the things that happened during the pandemic, is that by the end of it, not only have women experienced higher rates of domestic abuse or increased instances of domestic abuse, but by the end of it, their position is going to be even more precarious than it was at the beginning. There is a lot that we have seen, and we knew this as the pandemic was happening, and I was having conversations, for example, to access funding. I said to the funders, this is not, once the healthcare restrictions ease up, this crisis is going to be lasting for 3 to 5 years after that happens. And I have not been proved wrong in what we're seeing coming to services, so levels of debt, the fact that, for example, if you need emergency accommodation, you need to move houses, then suddenly you have to find new employment.
Yes.
All of those situations will carry on much, much longer, leading to worse outcomes in terms of equality. And I would say not only gender equality, but racial and ethnic minority equality as well. When you have two in the same person, then the effects are going to be much higher and much longer lasting.
Yes. I'd like to just pause and reflect upon two examples of what you've just described that you give in your statement. The first is in relation to domestic abuse victim survivors who were complying with lockdown restrictions, and so they they lost contact with their social networks. As you've described, perhaps they had been furloughed. They were spending a lot of time in the house. And so there was a reduced opportunity for services to identify that abuse that was happening. And at paragraph 65, you describe the example of an older victim survivor whose husband was controlling her movements and not allowing her to leave the house. And the first time that she did leave the house was to go to the vaccination centre, and that the vaccinator had attended training at the Solace Women's Aid refuge space and was able to identify the signs of abuse, and in fact arranged for that older woman to go straight to a refuge from the vaccination centre. She had it spotted from somebody, but the point, I suppose, is that because she'd been following lockdown restrictions, she had been at home with her abuser for a long time, and there was no outside agency able to identify that was happening and to take measures to stop it happening. The second example that you give is at page 5, paragraph 72 of your statement. The statement INQ number for our record is 000652188, and it's the case study of Josephine. Are we able to display that? We can, thank you very much. We're back in business. We can see here that Josephine was referred to Solace Women's Aid before the pandemic following serious physical assaults. After reporting the abuse and seeing her perpetrator cautioned, she felt empowered. When the pandemic started, she had minimal contact with her key worker due to her demanding role as a key worker. In April, A&E referred Josephine back to Solace Women's Aid. She revealed she had avoided contact because she didn't want to admit she had moved back in with her abuser. She explained that she felt she had no choice to do this because she needed to protect a vulnerable family member who was shielding, and as a key worker, she feared infecting them. The abuse had escalated and she felt trapped, and her key worker then secured temporary accommodation for her, but the perpetrator persisted with continued contact attempts, fake social media profiles, and spreading false information about her to friends and colleagues. The reason that I wanted to pause on that example is that the inquiry heard last week that it isn't just victims of domestic abuse who matter. It's also other family members, and lots of women have care responsibilities for other family members, and there needs to be a consideration of the effect of moving out of the family home that will have on other family members. Is that something which your organisation has experience of, and how might that lead to domestic abuse victim survivors remaining in the family home when really there is an alternative? Yeah,
I mean, we see it a lot, particularly with women with children, that they, as I said, they're really good at assessing risk and also at taking responsibility for those on their care. In our experience, part of the problem is that the conditions for them to safely exit situations are not always there. In this case, it was because the family responsibility, but in a lot of cases that we see, and Saho Black Sisters sees as well, is generally because they're not offered a place to go.
Right.
So all of these considerations are always revolving around in the minds of survivors. They're constantly assessing, they're constantly reassessing and making the decisions that are best for them given the circumstances. I think one of the key things to think about is how we can make those circumstances a lot easier for them to not only safely escape, because the second example that you were presenting to us, she left, but she was forced to come back in light of the circumstances. How can we make those circumstances such that survivors not only can escape the abuse, but can do so in a way that's sustainable for them and for the people under their care?
Thank you. In terms of the types of domestic abuse that were seen during the pandemic, I'd just like to put up onto the screen, please, 2 paragraphs from the Domestic Abuse and Safeguarding Roundtable Summary Report at page 7. And in fact, could we please just highlight paragraphs 16 and 17? We'll start with paragraph 16, please. Thank you. Most representatives suggested that generally the pandemic did not directly lead to people becoming perpetrators of domestic abuse for the first time. Rather, the greater access to the victims allowed existing perpetrators to carry out abuse more intensely and in different ways. However, there were some instances of perpetrators committing abuse for the first time, and the representative for the Convention of Scottish Local Authorities noted that the financial and economic strain of the pandemic put additional pressure on households. They described how it had been reported by frontline services that there were people who had never experienced domestic abuse seeking support because their family's financial situation had led to abusive behaviour beginning. So both situations appear to have occurred. Some perpetrators abusing for the first time, but others certainly taking advantage of the additional access to the victim survivors.
I mean, I'm always a little bit worried about when we make these categorizations. And of course, the economic situation in a household will have an impact on the dynamics that are developing within that household. But what we need to remember when we're talking about domestic abuse is that this is about power and control. Domestic abuse happens where power and control are allowed to exist, where, you know, somebody is able to control somebody for whatever reason. And it decreases where power and control dynamics are disrupted. So it's difficult to say, you know, that increase in domestic abuse happens because of the economic situation within a household. It's really more about where power and control dynamics are able to flourish and are able to be exerted. So it might be that, you know, these perpetrators have exerted power and control in other ways, by different means. It wasn't recognized as domestic abuse, and in this situation, it does become recognized. It might be that victims themselves don't understand what they're experiencing is domestic abuse. As it happens, you know, some of the behaviors are so normalized within society that it becomes very difficult for survivors to understand this is what's happening.
Yes.
I would say, yes, there were cases of new perpetrators and new victims of domestic abuse because the situation enabled those new cases to come forward. And where economics might have been a factor, but it's definitely not the defining factor, as well as perpetrators that saw an opportunity to further perpetrate domestic abuse against their existing or perhaps new victims, which might also be the case.
Yes.
If you remember, once we all had to go in, this is not part of our evidence, but I read in the papers, people decided who were in new romantic relationships that they were going to isolate together.
Yes.
And this might be that the victim had not experienced domestic abuse, but the perpetrator had perpetrated domestic abuse. So it's really about understanding how the pandemic enabled these dynamics to happen and to continue uninterrupted.
Thank you. I'm going to turn to paragraph 17 in a moment and then just ask that we look also at paragraph 20. But in terms of the exacerbation of existing patterns of domestic abuse, you provide 3 examples in the report, in your statement. You say economic abuse, controlling and coercive behaviour, which you referred to, and also physical and sexual abuse. Yes. And so with that in mind, let's look at paragraph 17 of this summary report. The nature of sexual assault in particular also changed during the pandemic. Rape Crisis England and Wales saw a rise in complex sexual abuse cases during the pandemic. For example, those cohabiting with their perpetrator during the pandemic often experienced a higher frequency and sometimes severity of rape and sexual assault, given the increased opportunities the perpetrator had to abuse. As lockdown restrictions were eased and women were able to access services, Women's Aid England saw there had been an increase in the frequency and extremity of what victims and survivors had suffered or were suffering, given they were trapped in homes with perpetrators for a longer period of time without a clear escape route. And if we just look finally on this topic, please, at the experience of Hourglass, which is an organisation supporting older people experiencing abuse. They described how sexual abuse cases reported to them towards older people doubled during the pandemic. They said the majority of their calls related to familial abuse, with calls relating to abuse perpetrated by neighbours also increasing significantly during this period, doubling from 3 to 6%. There was an influx of cases involving adult grandchildren committing abuse when staying with their grandparents or great-grandparents because their parents worked in key worker settings and tried to limit their contact with their children to avoid exposure. And restrictions on leaving the house gave more of an opportunity for perpetrators within old people's homes to commit psychological, sexual and physical abuse. Thank you. We can take that down now. In terms of new patterns of domestic abuse, you provide 4 examples in your statement, and this evidence begins at paragraph 105. You describe exploitation of pandemic-related fears and restrictions, of technology-facilitated abuse. Is that where a perpetrator may seek to restrict the level of access that a victim survivor has to using a computer to contact services or to contact relatives and friends?
It's both the restricting of access, and sometimes it wasn't as sophisticated as controlling a computer. You can just plug the Wi-Fi out of the router, out of the socket, and then that's it, no data. But also in the use of technology as a method of surveillance. So you have seen in phones, find my friends, and suddenly you're available to whomever is tracking you. Yeah. And of course, much more sophisticated surveillance methods.
And you also provide examples of misuse of government messaging. Yes. And also use of infection control measures as abuse. Can you give us an example of those types of new patterns of domestic abuse, please?
Yes. So the misuse of government messaging, it's very simple. Once you were told to stay home no matter what, and then the nuances don't come forward until months later, it's very easy to keep reinforcing the message. If you leave the house, then you're going to be non-compliant with the required regulations. What was at that point the law of the land, without necessarily going into what exemptions were made for survivors of domestic abuse. Not that it was clear in the beginning. In the beginning, I think it was more about if you're experiencing harm than actually saying if you're experiencing domestic abuse or other forms of violence. And then, sorry, I forgot the second part of the question, if you can repeat it for me.
It was the use of infection control measures as abuse.
So, again, if you are being told to stay at home or if you have to leave because of work requirements, if you're a carer or if you work in healthcare services or if you're a cleaner, then the easiest way to disrupt that is to infect you. And because at that point is really what is coming through in the news constantly is how scary the situation is. You will do the best you do to avoid it. So if I essentially go and tell you, I'm going to go out because I'm going to go out, and then come and cough on you, of course, that is a way of controlling. I would probably just add that one of the things that we saw during this period that relates to both of these things is the lack of information made in different languages. And that might include other languages. We use Spanish and Portuguese, but we know that other languages, including BSL, were not included in this messaging, which made it a lot easier for perpetrators to act with impunity with certain groups. As well as, the clear messaging around how domestic abuse survivors were going to be supported first and foremost. That was also clearly accessible to communities like migrant communities that were subject to immigration restrictions, and so on and so forth. It's just about, if you do not have a message that's very clear, very easy to understand, and accessible to people in whatever language they need, then you're giving perpetrators the perfect opportunity to continue exerting power and control over their victims.
Thank you. Your joint statement, which has been prepared, I know, by all three organisations that make up the DA group, contains many illuminating examples and case studies of how the pandemic and the restrictions affected women. And I'd like us to look, please, just at one of these. It's the case of Valeria, which begins at paragraph 138. She contacted your organisation for the first time during the COVID-19 lockdown. She was living with her husband, their 2 children, and her eldest son from a previous relationship. Prior to the lockdown, she described her relationship as bearable. While there were occasional disagreements and some controlling behaviours from her husband, the situation had not escalated to what she recognised as abuse, and that's something which you've touched upon this morning. However, the enforced proximity and pressure of the lockdown significantly altered the family dynamic and exacerbated pre-existing issues. During the lockdown, Valeria reported an increase in verbal, emotional and psychological abuse. He frequently belittled her with comments about how stupid and useless he thought she was. She described feeling suffocated and trapped at home with nowhere to go and feeling emotionally worn down by the constant criticism and belittling from her husband. The lockdown brought to the forefront the extent of her husband's controlling behaviour, which had previously been less apparent due to their separate work schedules and social activities. Valeria's children also began to witness and experience the increased tension and conflict in the home, which added to her distress and concern for their well-being. About a month later, Valeria contacted Latin American Women's Rights Services again to report that her husband had returned to work and her son had resumed school, which had significantly eased the tensions at home. The reduction in time spent confined together had led to a noticeable improvement in their relationship dynamics. The case illustrating how the lockdown period brought to the surface or intensified abuse behaviours that may otherwise have remained hidden or less severe. Thank you very much. We can take that down. I'm going to ask for you to touch briefly, please, upon the impact on service demand and access to support services, because we've covered a lot of this. There was digital exclusion, as we've touched upon, lack of safe spaces for remote access to take place, which you've already described at the beginning of your evidence, and language barriers which existed and continued to exist. In terms of refuge accommodation challenges and challenges in housing and access to disruption generally in this area, you describe at paragraph 184 something called gatekeeping practices. You say that in housing offices, when domestic abuse victim survivors approached local authorities for support, there were increases in questions being asked repeatedly, and evidence being sought for complaints that were being made. Did that have an effect upon the willingness of domestic abuse victim survivors in going to seek assistance from local authorities?
Yes, of course. I mean, domestic abuse survivors usually are under such pressure, such stress already, that what they need is a system that will facilitate that. But we saw it with local authorities and housing as well. Even caseworkers at the Latin American Women's Rights Service, we had to spend 2, 3, 4 hours to talk to someone about accommodation. The moment that survivors realize that the system is not going to be there for them to help them in this situation, they reassess and say, okay, so as long as my life is not at risk at this immediate moment, then maybe I can hold off a little bit, go back to an abusive situation. So yeah, it has a massive effect. And once you know, the statutory services, housing and others, it might be healthcare, it might be the police, continue putting barriers in front of survivors, what will happen is that the narrative brought forward, usually by perpetrators, nobody cares, nobody will help you, starts becoming a reality for the survivors. So it will disincentivize survivors being able to come forward, because what they're seeing is that the perpetrator is correct. Nobody cares and nobody helps. So I'll do what I have to do in order to stay as safe as possible.
Yes.
And that might mean remaining in abusive situations for longer.
And you describe in your statement how some initiatives which were brought into force by the government, such as the Everyone In initiative scheme, had many positive impacts. But of course, there were challenges for instance, women with no recourse to public funds who feared losing their immigration status if they accessed the scheme. What measures, in your opinion, would have helped to make that scheme, taking that as an example, more effective for women with no recourse to public funds to help mitigate the impacts of the pandemic?
I mean, I think women with no recourse to public funds should have had that condition lifted for the duration of the pandemic as an emergency measure in making sure that we're not putting them at risk. For the simple reason that with schemes like Everyone In, there's a big problem with mixed accommodation, for example. So you might be able to access something, but you would have to be strict homeless in order to access Everyone In. But you don't know who is going to be your neighbor in that accommodation. If you have children, then the risk of something happening to you or your children increases, as well as the mental health effects of being in an unsafe environment. So moving from a very unsafe environment to a slightly less unsafe environment, but continue to be unsafe. One of the things that we saw at the beginning of the pandemic was very simple messaging with very broad measures. Stay home, stay safe, save others, support the NHS. But with no recourse to public funds, well, I mean, if you fill these conditions, maybe you can access this. It's very complex for survivors themselves to come and ask for support.
Yes.
As well as statutory services to provide it, because the messaging is so complicated.
Confused.
A very broad lifting of no recourse to public funds would have had a significant effect, because then both sides of the conversation would know you have access to state support for the duration, which was possible. We saw it with the furlough scheme. We saw it with other schemes. Resources were made available to support other areas of the population that the government knew were going to be highly impacted by the pandemic. What I cannot, to this day, still understand is why victims of domestic abuse did not have that same level of response, of consideration from the government, which would have been, I would say probably no more impactful on the economy than, the furlough scheme.
Yeah, we have to be careful because we aren't a decision-making module.
Sorry.
No, you don't need to apologise. But your evidence is clear on that point. But despite the challenges, the three organisations that make up the DA group developed innovative approaches, didn't they, in order to maintain support. Can you tell us what those were, please?
Yeah, I mean, for some of us, it meant moving completely to online remote provision, and
Yes.
that might have been over the phone, over chat, over websites. There were multiple innovations that were done. But I have to say, for some of us, it meant going into the community and remaining within the community to make sure that those women that would have, for example, barriers to access technology would
Yes.
still be able to access services.
Some of the challenges that were apparent related to the impact of the pandemic and lockdown on law enforcement, didn't they? And
Yeah.
I'd like to turn now to look briefly at that. And were those challenges involving both access to legal support and legal advice and also delay in court proceedings?
Yes.
Yeah. You tell us at paragraph 228 in the statement that the pandemic caused huge delays to getting victim survivors legal support. Solicitors were working over capacity. It became challenging to find somebody to provide that legal advice, and court delays became severe. The impacts, as I'm sure everybody in the country is aware, have persisted beyond the end of the pandemic. But I'd like to ask you in particular about family law proceedings, because at paragraph 231 in your statement, you say that as well as criminal and civil cases, family law proceedings were affected in a similar way. There were long-term consequences of delays in those hearings that were either postponed or cancelled due to lockdowns, and that had a direct effect on, for instance, non-molestation orders or child protection proceedings.
Yeah.
How were your organisations able to provide support in relation to these delays and lack of access to justice procedures?
Where it was possible, we increased our reach. We work over time. We work with others in trying to do this. In some cases, for example, we were asked to provide translation services, and caseworkers just did that in order to enable that to happen. Generally, we continue doing what we have been doing for a very long time, which is to support survivors within the existing conditions in the best way that we are able to. But really, 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 it was a lot of caseworker, frontline worker, key worker hours put into that in order to facilitate those processes. Because we knew that the longer these things were going to take place, the higher the risk for survivors and often for their children were going to be.
Thank you. Let's look briefly, please, at the impact of the pandemic and lockdown on health and well-being. You tell us that the pandemic had profound and lasting effects on the health and well-being of domestic abuse victim survivors. The combination of intensified abuse, isolation from support networks, and reduced access to mental health services, all of which we've covered, created a perfect storm of psychological distress that continues to affect some victim survivors today. Yeah. I'd like to display, please, the Every Story Matters mental health and wellbeing record. It's at INQ 000659895 at page 35. And we can see here that this section of the record relates to impact on victims and survivors of domestic abuse. The Every Story Matters team heard from victims and survivors of domestic abuse who were confined with their abusers without any opportunities to escape their home for respite. They told us about how scary and stressful it was to be unable to leave their homes. Some told us about how they were unable to access support services that had previously helped them. Children and young persons' experiences of domestic abuse or living in a household with domestic abuse during the pandemic are explored further in the Module 8 Every Story Matters record. But one contributor from England told the Every Story Matters team, "Being on my own with no support didn't bother me at first, but when I had to deal with re-triggering domestic abuse from my youngest's father, I felt terrified, isolated, and very alone. I'd had support in place before, but couldn't access the services needed once the pandemic hit. I was scared and couldn't sleep in case my ex came round drunk. The stress was intense. I couldn't focus on my PhD and was also trying to balance homeschooling. I'd be scared of coming home to find my ex waiting, or worse still, in the house." Does that chime with the experiences that your organisation was hearing about?
Yes, definitely. As this case was being read, I was thinking about the case that we put in our evidence from Mariella,
Yes.
where she was saying, "I work as a cleaner in St. Thomas Hospital. I am the one who cleans after they take the bodies of people who died from COVID-19, and I still feel safer than at home." So the experiences are quite similar. I think the effects of living through domestic abuse in an isolated context where there is a massive gap, and we heard that from testimony early today and from Mind when they gave testimony last week.
Yes.
The fact that the support is just not there, and you're trying to scramble how to deal with this situation without having the tools that would make it much more bearable, became a massive crisis. And I think for survivors of domestic abuse, we're going to continue seeing the effects of all of this happening to them at the same time for a very long time.
Thank you. Turning to lessons learned, you've covered many of them during the course of your evidence, Ms. Ballet. I will seek to summarise what appears at the end of your statement, and please feel free to add any which you want to add. Earlier interventions and funding,
Yeah.
a comprehensive messaging, clear messaging and guidance,
Yeah.
joined up services, improved coordination. That's in relation to public services, schools, medical services and frontline charities. Considering and dealing with long-term housing challenges, recognition of key workers, and data collection, which the inquiry has heard a lot of complaint about. Improved data collection across all of those who are likely to suffer domestic abuse. Is there anything that you would like to add to that?
I think I would say that we need to have a much better understanding of how different groups are going to be affected disproportionately by this, and what measures need to be in place in order to support these differences. As we were talking about data, it keeps reminding me how the women that come through our services, for example, are almost always absent from this data, either from statutory services like the police or sometimes from national charities, just because these women are not going to access those services. At the same time, although the whole country experienced what was a really difficult, life-changing moment, the way that the women coming through our services experienced it was, if it's possible, much bigger in terms of scale and in terms of the disruption to multiple areas of their lives. At this moment, two things that are very key are going to continue to happen. So while housing, healthcare, police, and others are almost impossible to access, the enforcement of border controls will remain intact. So you will have problems contacting the police, but the police will experience no disruption whatsoever in informing the Home Office immigration enforcement team. We know that because of lack of access to healthcare, the health situation of these survivors was much more precarious, and yet the provisions are not made in how can we take into consideration these pre-existing disadvantages that will have disproportionate effects on these populations and do something with it. With domestic abuse, it's very simple. I mean, The Guardian reported that the increase in cases of domestic abuse was coming, and yet it took a very long time to find the funding and put it in place in order for us to support these women. A lot of the things we had to do, and I know that our evidence covers things like burnout, we had to do ourselves. So I would say we need to understand much, much better who is going to need what kind of support much faster, through the use of reliable data. We need to put measures in place that are broad-reaching enough and simple to understand enough to have the effect of supporting these groups. And we need to seriously look at how the disproportionate effects in particular groups are going to have a much wider effect on the totality of the population. We talk about, Mariella, who was a cleaner at a hospital, who is in a hospital setting in context with healthcare providers and in contact with, people who are coming to access healthcare services in the context of a pandemic. And yet, we don't give enough consideration as to how putting her at higher risk of domestic abuse, of getting sick, of falling destitute, will create a higher risk further down the line, and so on and so forth. So I think it's understanding the differences that will put people at risk, women, children, Black and minoritized communities, Mayan communities, to put the measures in place quickly to address this and to link how the different areas of life are going to impact these same communities to the detriment of the entirety of the population. Because again, these were our health workers, these were our carers, these were our cleaners, these were, all the people that we said were essential during the pandemic were put at risk unnecessarily.
Yes.
So better measures to be put in place. We know about the funding. We know about the suspension of certain conditions. We know about data collection. But it's really about having a much more nuanced picture that allows us as a country to respond to a pandemic in a much more prepared way when the next one comes on.
Thank you very much, Ms. Ballet. My lady, that concludes my questions. You have given permission for a question to be asked on behalf of Migrants' Rights Consortium by Ms. Wiranatne, King's Counsel.
Thank you. Ms. Wiranatne.
Thank you very much. Thank you, my lady. Ms. Ballet, I act for the Migrants' Rights Consortium. A key concern for us is understanding and the planning for migrant groups excluded from essential services and subject to NHS charging and data sharing with the Home Office.
Yeah.
You've just been asked about data sharing, and at paragraph 236 in your witness statement, you deal with data sharing between the police and the Home Office.
Yeah.
You discuss a firewall
Yes.
recommended by 3 independent police watchdogs for the purpose of preventing all communication and data sharing between the police service and the Home Office on migrant victims of crime, obviously including domestic abuse, in the interest of bringing to justice individuals breaking the law.
Yes.
Now, this firewall recommendation was responded to by the Home Office in a review that it then conducted in December 2021.
Yes.
And there's a report that you refer to. And you say that the Home Office rejected this recommendation
Yes.
for a firewall and the proposal for either a full or time-limited firewall, so complete refusal.
Yes.
So the question is this, whether your group of organisations has seen or are able to say what was the impact of that decision on migrant victims of crime during the pandemic?
I think you can see from the evidence provided on the lack of increase of reports to police, there's a correlation that can be made. We know that migrant victims of crime generally don't come forward because it's unsafe for them to do so, because instead of having the crimes they're trying to report, like domestic abuse, sexual abuse, and other criminal activity, their data is shared with immigration enforcement. And that leads to a lack of police investigating the actual crime being reported, whilst immigration enforcement actually takes action against the victim that's trying to come forward for whatever reason. So what we have found is that migrant victims are generally prevented from reporting crime to police because the fear of the data sharing is so high that they rather take the risk of, continuing in domestic abusive situations and other types of situations. We did some research in 2019 when it was very clear that
I'm sorry to interrupt.
Sorry.
Could you make sure we keep to the pandemic as opposed to the general principle, Ms. Valley?
Yes.
Thank you.
Yes, so we understood that survivors who were subject to immigration control were unlikely to come forward during the pandemic because of the fear of data sharing and the fact that no provision was made to stop data sharing to enable these survivors to come forward.
And just to answer the question that my lady has just posed, and that was something you saw during the pandemic, and was there a difference at that time?
So we saw that before, during, after the pandemic. I think the biggest difference was perhaps how the data sharing kind of compounded other restrictions at the time that made, survivors less likely to approach to the police as they would, services like ours. So I think, the fact that you have more or less little change in police data around reporting, but very high change in terms of, the demand for services, really talks about, survivors not coming forward. In the case of migrant survivors, it was generally understood that because the data sharing was maintained, unless the situation was really high risk, they would not approach statutory services. The police first and foremost, but not the only one. We know that, other statutory services like healthcare services, for example, also share data with the Home Office. And we know the effect that that has is that generally migrant communities, victims of crime and otherwise, will stay away from those statutory services.
And so just to complete that, so I think what you're saying is that the fear of coming forward, the fear of affecting immigration status through reporting and data sharing is one that prevented migrants from accessing services.
That is correct, yes.
Thank you very much.
Thank you very much. Thank you very much, Ms. Farry. I appreciate you've got an awful lot to tell me, but as you know, I've got to focus on this module, and it's really important stuff. I do understand that, and I do understand why you occasionally went a little bit off piste, but I'll forgive you because I know how important it is. So thank you very much for your help with the inquiry, obviously producing the report and being such a very good advocate for the cause that you and your colleagues support, and it's a really worthy cause. And thank you for the work you do.
Thank you very much.
My lady, that completes this morning's evidence. May we pause for lunch, please?
Certainly. Probably need a break, Ms. Blackwell. I shall return at 2:15.
Thank you very much.
Thank you.